Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of May 12, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After an update on respiratory viruses and measles, I will try to make sense of some of the news coming out of the federal government on vaccinations, and I'll review a new vaccine trial. First, taking a look at respiratory viruses among patients who present to a healthcare setting for testing. As of May 3rd, the largest share of cases is made up by rhinovirus enterovirus in the gray line, followed by human metapneumovirus in the black, followed very closely behind by para-influenza virus in the yellow, and those are all increasing in proportion. And it's important when looking at this to consider that COVID, which is in the red, can be easily ruled out prior to or instead of getting tested in a clinical setting. So by the time people are showing up to the doctor's office or the urgent care, there's a good possibility they may have already done a COVID test and found out that it was negative. So when I look at this chart, I'm recognizing that what's represented here is going to exclude a lot of people who tested positive for COVID at home. But still, that factor should remain more or less constant. We now have COVID tests out here, even though they are expensive and we're not getting them for free anymore. But you can get them, and many people will opt to spend the money on a home COVID test if they're not super sick and if they can avoid going in somewhere to get tested. Also, many public health departments are still distributing COVID home tests. Don't know how much longer that will last. But with all of that being said, the ability to do at-home COVID testing being more or less constant, this still gives us an idea of the relative proportions and what direction they're kind of moving in. So we'll still continue to look at these proportions, but with COVID in particular, it's really not going to be the main indicator we're looking at. We need to look more to wastewater and epidemic trends and emergency department visits and hospitalizations and deaths. But I will take this opportunity to say that this effort to test for COVID at home when you don't feel well really should be preserved and encouraged. There are other countries where these tests are available for pennies, a dollar or two. I really wish that was the case here in the United States. It should be really simple to find out if you're positive so that you can do what you need to do in terms of getting treated, if you're someone who needs to be treated, and also to not go around others and get them sick. And certainly before gathering indoors with those who may be vulnerable to a bad outcome, which is a huge segment of the population that you're not always going to be able to identify. So that takes us back to just basically not going unmasked around others, and certainly not if you're not feeling well, and testing to rule out COVID is an important strategy. So if you feel unwell, test to rule out COVID. And if you have access to the combo test with the COVID and flu, that is even better. I know those are even more expensive and not quite as readily available, but generally speaking, those who should get treated for COVID if they get it should also get treated for flu if they get it, to prevent progression to severe outcomes. And remember that you really do need at least 2 COVID tests spaced 24 to 48 hours apart after symptoms get started before your accuracy is pretty decent with the home antigen tests. And now taking a look at epidemic trends, where modeling is used based on emergency department visits to determine which direction things seem to be going. And this is looking at COVID. Most states are either not changing, represented in gray, or they are shades of green, indicating that they're declining or likely declining. Hawaii in the purple is the only state right now where COVID is likely growing. And when it comes to influenza, the vast majority of the country is declining, and it's not growing anywhere in any state. So that's definitely good news. And hopefully we can not have to talk much about flu or RSV for that matter until late summer, early fall, when the new season is anticipated to kick off. And although cases are really slowing down and the season seems to be mostly behind us, 10 more pediatric deaths have been added since I reported last week. So now that's a total of 226 pediatric deaths And we know that the vast majority of these could have been prevented with vaccination. So we really need to do better here. I'll be able to give more specifics, hopefully after the June meeting of the Advisory Committee on Immunization Practices, where we anticipate that they'll review some analyses of the vaccine data for flu from this past season. And taking a look at hospitalizations from COVID, flu, and RSV, flu is represented in blue. You can see hospitalizations on the left, deaths on the right, and both hospitalizations and deaths for flu have now dropped below those for COVID, which are represented in orange. And so we'll anticipate that that will remain the case until next season. And when it comes to US COVID deaths, those also continue decreasing. So that's good news. There were still 337 deaths so far recorded for the week ending April 12th. And last year, we reached our low point the week ending June 8th, 2024, when there were 314 deaths. But from there, it did tick back up, and we ended up with a couple of months where every single week we had over 1,000 deaths. So I'm really hoping we can do better this year, and we know that that will be from timely testing, timely treatment, and then staying up to date on vaccination, which for those 65 and up or those immunocompromised means that they should get a second one probably around this time. So roughly 6 months from the last one, and hopefully before higher risk activities over the summer and before we head into a summer wave, if we're going to have a summer wave. So we'll just have to wait and see. And now a brief update on the US measles situation. As of May 9th, there were 1,001 confirmed cases. So this is up from 935 last week, so an addition of 66 cases. So thus far, 126 people have been hospitalized. There have been 3 deaths in the United States. 2 were otherwise healthy children. 1 was an adult, and there was actually a 4th that was associated with this outbreak, but this was an adult who died in Mexico. Last year, the entire year 2024, there were 285 cases. So already in 2025, not even halfway through, we've had over 3.5 times the number of cases we saw the entire year of 2024, and 93% of those are outbreak associated. By comparison, in 2024, only 69% were outbreak associated. So things don't seem to be slowing down, and it's becoming more and more likely with each day that passes with increasing cases that the United States could lose its measles elimination status, meaning that measles will basically become part of our new normal, which is disgraceful. And, but this is the reality we're in. So I think as a result, it is important that we are familiar with some of the basics. Last week, I reviewed the CDC's measles page. So you can take a look at last week's briefing if you want to see that overview, but I also linked the page in the post. And last week, I referred to an infographic on what to do if you think your child has measles. So I'll go over that in just a little bit more detail because I think this is important. Measles will usually start with a fever, cough, and runny nose, so it can look like a lot of things. Then red eyes, and then that typical rash, which kind of starts at the forehead, top of the head, and makes its way down. So what you'll want to do right away is keep that person, the child, the individual that you suspect having measles away from family members. And everyone, though, in the house should stay home while this all gets sorted out so that you don't get other people in the community sick. And you should call the doctor or hospital right away to let them know that someone in your home is sick with measles, and they will give you instructions from there. Now, when to go to the emergency room, this is also really important information. So trouble breathing, pain when breathing or coughing, dehydration. So this is when the nose and the mouth, those mucous membranes start to look dry and there's less urination, crying without making tears. So especially we're looking at this in little children, fever or headache that won't stop, definitely confusion or decreased alertness or severe weakness, or any signs of low energy, difficulty feeding for babies and young children, or any blue color around the mouth. And have someone to call the emergency department or the hospital to let them know you're on the way. They need to get their protocols in order to also make sure that we don't get the entire waiting area or other patients sick with measles as well, knowing how highly, highly contagious it is. So now I'm going to take a moment kind of in this context to try to make sense of some of what we've been hearing from the federal government as it relates to changes in our approach to vaccination. And I've just alluded to one of the outcomes of our government's new approach to vaccination, which is really marked by introducing skepticism and doubt about vaccination, despite the fact that there's no evidence whatsoever that we should be doing that. And despite the fact that there are mountains and decades of evidence that clearly support the importance of vaccination. And that's a situation that we find ourselves in with respect to measles, where we haven't seen outbreaks like this for over 2 decades. And to suggest that this approach is any sort of improvement or is in any way making us healthier is just pure nonsense. And as we've seen, people in government who are not treating patients can apparently say whatever they like without evidence or repercussions. But at least so far, physicians and other medical providers are still required to uphold standards of care. And we should certainly be held accountable to our oath and our commitment to do no harm. So doctors choosing to abandon standards of care by failing to recommend age and situation appropriate vaccinations should certainly be held accountable by their associations, by their medical boards, by their colleagues, and by their patients. So I, for one, take what I'm hearing out of Washington with a big grain of salt, knowing that as a physician, like other physicians and medical providers, I have a duty of care that does not change because people in power express their thoughts and feelings without evidence. And when they do rattle off numbers and statistics, it remains incumbent upon me to fact check them. And it really is quite astounding that oftentimes it's clear that these statistics are made up, and what is being communicated too often are lies and half-truths. So having said that, it's still difficult to really parse what is being said, if it is something that's truly going to be undertaken versus more like threats or bluster or just words. So some of it seems like rhetoric or a way to take credit for things that are in fact not new. Some of it is probably a watch and wait and see situation, but some of it is definitely a cause for concern. So first, I want to try to address this news that HHS, Health and Human Services, announced that it would be developing a so-called next generation universal vaccine platform called Generation Gold Standard. And the press release about this is linked in the post, but basically, even though it has a lot of buzzwords like transparency and gold standard and paradigm shift, what it's actually talking about is old technology, it seems. It's talking about inactivated whole virus platform, which is something that is not new. And it's not clear how this is going to help us to achieve pandemic preparedness, which is the stated goal. So the goals that they put forward and the ideas they're discussing here are important ones. So much so that they've actually been worked on for many, many years by many scientists, and this is not necessarily anything new. But they do reference a couple of things I know we've talked about here as being part of the direction we really want to go in the future, and that includes a mucosal vaccine. So one that you might spray into the nose that could ideally block transmission of respiratory viruses like SARS-CoV-2, among others. And the other is a vaccine formulation that can protect against multiple different strains, kind of a variant-proof type of a vaccine. And I know I've talked here many times, and many scientists have talked about, and many doctors have talked about our need for a variant-proof vaccine, as well as vaccines that could stop transmission. In an ideal world, the vaccine could cover for more than just one pathogen, more than just one flu, more than just one coronavirus, and more than one variant. So this is nothing new. This is something that we know we want. So it is somewhat reassuring that the announcement reflects goals that I think most of us share. And pandemic preparedness, a strategy that does not require chasing variants every 6 months or a year, and technology that could go beyond just protecting us from severe disease, but could actually play a bigger role in blocking transmission. These are all great goals. So the press release states that they are targeting FDA approval by 2029. A little thin on details of how we would get there by 2029. They did not talk specifics about who exactly would be developing, whether there's going to be industry partners, how much will be invested. But there was a Wall Street Journal report that says that they received email communications from the White House saying that 500 million would be invested into so-called Generation Gold Standard. And it does appear that the project is going to be conducted by scientists within NIH. So it's because it's researchers inside of NIH, it's a little different than, for example, if researchers at a university or somewhere else were trying to get NIH funding, then we would kind of know what the review process was, which is a very rigorous process. So with it being done in-house, despite their saying there'll be more transparency, that hasn't been forthcoming just yet. So we'll definitely be keeping an eye out for that. So far things seem pretty vague. It does seem a little odd that with a possible $500 million investment that they wouldn't be exploring the use of newer technologies. And so it's kind of unclear why they're wanting to just hang their hat on this old technology, especially because our attempts in the past to create a universal flu vaccine this way have been unsuccessful. So maybe they know something we don't know. I'll definitely be interested to see what comes out of this. Hopeful that we get a better flu vaccine and better COVID vaccines, because there's no question that we need them. We know that we continue to see quite a lot of sickness, hospitalization, and death, not only in our elders, but also in our children. And if we can do better than this, that would be great. If we could find a strategy that doesn't require vaccination every year, that would also be amazing. But there's still just a lot of unknowns, so I'm hopeful that more details will be forthcoming soon. And along the same lines of sort of claiming that something old is actually new, we also heard these reports that HHS Secretary Robert F. Kennedy Jr. plans to change the way that vaccines are tested by requiring placebo testing for new vaccines. So I think we all know that vaccines already require placebo testing when it is a new vaccine. So we reviewed many times in quite a lot of detail the massive placebo-controlled trials that were undertaken for the COVID-19 vaccines. So half of the people got the vaccine, the other half got placebo. So that's really how we test new drugs and new vaccines already. When established vaccines need to be updated, such as the annual updated flu vaccine or COVID vaccine, a placebo-controlled trial is no longer needed. And in fact, it can be unethical or harmful. And that's because if you already have a safe and effective way to prevent a disease, it would then become unethical to withhold that from people just so that they could get a placebo. And that's what you would have to do a placebo trial. So normally what we do is something called a non-inferiority study, where instead of using the placebo, we use the old vaccine so that the new vaccine can be tested against the old vaccine, which would have already undergone a placebo trial. And I'm going to give a recent example of that in a couple of minutes. But here again, there's quite a bit of vagueness about what is actually going on here. So we don't know which vaccines this is going to apply to. We don't know how HHS is going to define new vaccine. They did indicate that they would not count the flu vaccine as new, which is a good thing, but it remains unclear whether, for example, the COVID vaccine will be considered new or any other vaccines where we're trying to improve upon an existing version. So again, it's unclear what real impact this is going to have. And it's going to be important that we keep an eye on this because we want to make sure that vaccines don't become less available or less accessible or less affordable due to these unnecessary barriers. And it really is not clear to me what we're trying to solve for. So again, it seems a little more like buzzwords rather than a strategy based on evidence or facts. So it seems entirely possible to me that we're actually not going to do anything different at all, but we're just going to say that we are. And that would probably be the best case scenario here, maybe wishful thinking on my part. Worst case scenario is that this really is an attempt to undermine our infrastructure and capacity and decades of success with vaccination, which would ultimately leave us a sicker and more vulnerable nation. And even if that's attempted, it remains to be seen if that would be successful or not. So we really are just going to have to stay tuned. I mentioned earlier that when we have a good vaccine that's already been studied in a placebo trial and that we know is saving lives and where we know the benefits far outweigh the risks, then we want to, and when we want to then try a new one, we can use a clinical trial design called non-inferiority. And that basically is what it sounds like it is. So it's where we want to show that the new treatment isn't worse or it isn't less effective than its predecessor. And sometimes what we're trying to solve for here, what we're trying to accomplish with a new formula, it could be that we are looking to, for example, cause fewer side effects, or maybe it's going to be a less expensive formulation or an easier to administer formulation. So you're comparing your new formula, which may have some advantages or should have some advantages over the proven formula, and you're trying to establish that it's just as effective. So that is a non-inferiority trial. And oftentimes a non-inferiority trial is chosen because of what I mentioned before, which is that it would not be ethical to use a placebo when we have a proven effective treatment or vaccine. And we have a recent excellent example of using this study design published in JAMA last week on May 7th. And this is called Immunogenicity and Safety of Influenza and COVID-19 Multicomponent Vaccine in Adults Over 50 Years, a randomized clinical trial. So this is a phase 3 study that was looking at the safety and the immune response from a combination vaccine. So it's a combination of flu and SARS-CoV-2 in adults 50 and up. So this was a randomized blinded trial focusing on those 50 and up, grouped into two different cohorts. The first cohort was 50 to 64 years old, and the other one was 65 and up. And the study included over 8,000 participants across 146 sites in the US, with very good distribution of gender, race, and ethnicity. And if you're interested in those details, the study is linked in the post. And they basically compared this new combo vaccine, which is called mRNA 1083, against flu and COVID vaccines that are currently available. So what did they find? First off, they did not find any safety concerns. They had similar side effect profiles to the currently available vaccines, but no safety concern. Secondly, the test vaccination mRNA 1083 met the non-inferiority criteria. In fact, it induced a greater immune response than the influenza vaccine we would give for the age groups here, so either the standard vaccine or the high dose flu vaccine. And it also induced a greater immune response than the Moderna COVID vaccine. And they were specifically looking at the immune response at day 29. And they also plan to look at the end of the study period, which will be at about 6 months or day 181. So this study was looking at the blood samples immune response data from day 1 and day 29, but we'll be keeping an eye out for these results at day 181 as well. That'll be coming out in the future. So I share this for a couple of reasons. First off, this is a great illustration of why we need to continue doing non-inferiority studies in many cases. Imagine how highly unethical it would have been to give 4,000 people 50 and up a placebo, knowing how vulnerable many of these individuals would be to hospitalization or death from flu or COVID. This would be completely unacceptable. I don't know if any review board would approve such a study. So I think it's likely that any unreasonable calls for placebo-controlled trials would be met with a lot of scrutiny, may not be able to pass a review board, and definitely the world will be watching if we were to deny groups of study volunteers the standard of care just to satisfy the whims of politicians. But most importantly, I'm sharing it because it's a bit of late-breaking good news. So despite all the other concerning signals we seem to be getting, good science is still being done. and this particular vaccine is showing promising results. We know that uptake of the flu vaccine and the COVID vaccine are too low. We're still losing too many people. And we need to see it much higher. We need to see the uptake much higher, particularly for the age groups that are at a higher risk of poor outcomes. So this very group, 50 and up. And if we could improve vaccine uptake, we would see the numbers of deaths and hospitalizations come down. And we know from our experience, especially with children, that when you can combine some of the vaccines, you're more likely to complete them. And especially while we're stuck in this annual vaccine strategy for flu and COVID, it's a short window to try to get both of those vaccines accomplished. So a combination vaccine could certainly help to improve uptake. So we will keep an eye out for mRNA 1083 to see how it makes its way through the approval process, which Moderna anticipates will be completed in 2026. With so many canceled and delayed vaccine meetings, as well as barriers being put in place, such as barriers for the approval of the Novavax COVID vaccine, it's just not clear how all of this is going to go. So more to come on that. In the meantime, let's continue to stay informed and do what we can to keep ourselves and our loved ones safe and healthy. If you don't have a primary care provider, please get one, develop a relationship with them, make sure you are getting the appropriate screenings and vaccines based on your age and risk factors. Eat a balanced diet, stay well hydrated, quit smoking, avoid alcohol and simple sugars and processed foods and artificial ingredients. If you don't feel well, make sure you get your rest. Otherwise, get some regular physical activity, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.